Hey, Ideal Protein Nation. Welcome to episode 26 of the Life Possible podcast. Hey, for those of you who aren't familiar with the show, the Life Possible podcast spotlights successful clients, coaches, and clinic owners who have used the Ideal Protein protocol to reset their body, reset their mind, and reset what's possible for their life. These individuals have truly had life-changing experiences, and now as a result are pursuing goals and dreams they thought were dead and gone. They're pursuing goals and dreams they never thought they could. And some of them are pursuing goals and dreams they never even knew they had. In short, they're living what we refer to as life possible. So who am I and why am I doing this? Well, I tell you what, my name is Dr. John Barnes. And there's no easy way to put this. 6 years ago, I found myself feeling fat, sick, and depressed. I had reached a new low, and I had pretty much given up. When I really, truly feel like God brought me the answer to my prayers, both personally and professionally, through the Ideal Protein Protocol. It's been now 6 years since I started that protocol. I'm actually over 70 pounds down from that picture, that initial weight of mine. And I'm living a life of where I feel healthy, vibrant, and alive. I've returned to the sport of triathlon after over 25 years of inactivity. And man, I tell you, Ideal Protein has become such a passion for me, and primarily because of the power of this protocol to transform you from the inside out. It's just so much more than weight loss. And so I know there are so many stories out there that I decided over the pandemic to start this show to find these stories and bring them so that you can understand what a powerful tool this could be for you to change your life. So who do we have today? Well, I tell you what, I'm a little bit nervous today. I've got one of my Ideal Protein idols, Dr. Tim Logemann. Dr. Logemann, he started a cardiology practice back in 1992, first as an interventional cardiologist for 13 years, and then shifted into non-invasive cardiology. The effects of the obesity epidemic and seeing the unifying diagnosis of obesity in most of his patients led him to open an Ideal Protein clinic back in 2012 and to pass the American Board of Obesity Medicine in 2016. He now makes obesity treatment an essential part of his cardiology practice. He has served on the medical advisory board for Ideal Protein since its inception. He's an avid fisherman, hunter, and family man. And I want you to help me welcome Dr. Timothy Logemann. Hey, there you are.
Hey, John. Thanks. Thanks for having me. It's quite an honor to be here. I'm really excited to chat with you and get some questions and have some ongoing discussion. I have to tell you, I'm a little bit nervous myself. I'm not usually a media type of guy. Watching myself talk here and working with famous internet people like yourself makes me a little bit see what we can do. I can already see that my fishing trip last week has had kind of a strange effect on my reflection here. You can tell I had my hat on, and you can see right where the brow bill came down to protect me from the sun. I don't always have this radiated appearance to myself. Usually, once it gets nice here in Wisconsin, then that'll get a little tan up there too. But anyway.
Well, yeah, but at least you're getting out.
What?
At least you're getting out, though, right?
I look like the trout we were trying to catch with the red face here. But anyway, thanks for having me.
Oh, no, it's absolutely a pleasure. Like I said, I've been a big fan of yours. You gave a great talk to our company a few months ago in the middle of the pandemic. And it was that show that really inspired me to want to have you on my show so that, we could get clients and coaches all across actually Ideal Protein Nation around the world to hear your insights. Because I think, again, your insights are super valuable as a practicing cardiologist and now obesity medicine specialist, having implemented this program very successfully on many levels with both your patients, but also in research type settings.
Yeah, thanks. I'm glad that we could help you, and I'm glad you found that talk enjoyable. And it's been fun to be part of this process for almost a decade now. So great.
Yeah. So yeah, you know what? Let's not stray too far. Let's talk about who the man Timothy Logemann is. Evidently, he's an avid fisherman. Yes.
I like to think of myself as that's right. Once in a while, work gets in the way, but we do try to make some time to get out there and get some fresh air. Absolutely, and try to stay active. You bet.
And it seems like you get your wife out there from time to time as well.
Loves to come along as well. That is correct. She's very supportive. I just drug her out to Montana last week, and in the wind and in the cold. Luckily, it didn't rain on us. But she's pretty good. That's her fish that she caught right there.
Oh, it's fantastic.
And then there's some couple of local sceneries here. We live in kind of central Wisconsin, Wausau, Wisconsin, and those are just some of the local places that we have to fish around here as well. So it's really nice. I enjoy. Well, like it says right on the slide there, life possible, right? That's why we do what we do for ourselves and for our patients and for our family to try to really enjoy things that are possible out there.
Yeah, yeah. Well, so I did get one picture from you, and I had received this from one of my friends, Andrew Likevall in Ideal Protein as well. Can you tell us the story of this fish? This is a huge, ugly fish.
It was also very tasty, by the way. So looks can be deceiving, right? Maybe that'll be the theme for today. But yeah, we that was down in Panama, actually, right before the pandemic hit. We seemed to come back just in time. We actually wore masks as a joke before the trip, if that makes any sense now. It's obviously not funny now, but at that point in time, that's trolling off the coast of Panama. You troll in a boat, and then the lures or the plugs, if you will, bring the fish up behind the boat. And then you can see in my teeth, which is kind of a classic fly rod pose there. You flip a fly off the end of a fly rod back at them, and then you pull the lure away, and then they eat the fly, and then you can catch them on a fly rod out in the blue water, 6-7 miles off the ocean. So
oh my gosh.
Yeah.
So that was a fly rod. That wasn't even like one of those big fishing rods that I see. You did that with a fly rod.
We did well. Fly rods come in different sizes. You're thinking of some of the smaller ones that you might use for trout or panfish, and this is maybe more inside baseball than what your listeners want to hear. But you can get a big fly rod that can catch big fish. It's a big, heavy rod, and so obviously for a fish like that, you're going to use a bigger rod, bigger reel, heavier line. But yeah, it was pretty cool. We were able to get them, and then because of the talk I did for Ideal Protein, they gave me a replica of that in my house. So. We have that in the fish room, as we call it here. So I get to look at it every once in a while. It certainly makes me smile and brings back some happy memories of what life is possible when you take care of yourself.
That's really cool. That is so cool. Yeah. So maybe you and Andrew and I should get together and go fishing sometime when things clear up and travel opens up.
I'm always in.
And then too, you're quite the family man. Family is very important to you. You sent me these great pictures.
Yeah, we do. My wife and I like to ski. Between my wife and I, now we have 5 children. She has 2, and I have 3. And we were just counting them up the other day, apparently, and now I guess we're up to 8 grandkids and
wow.
So I didn't really realize it until we took stock of who was all going to maybe be on one of our summer vacations, and it's getting to be pretty lengthy. The bottom there is my grandson, and we don't have any. Then we have my granddaughter up in the top there, and there's a bunch of other ones all in Illinois and Iowa and Minnesota and something.
Wow.
Yeah, right. So getting to be a nice big family. My son says it's rewarding. Sometimes I think it's it's a lot to kind of keep track of all of them, but he says I'm very lucky. I'll go with that.
Yes, I think we can all agree that if we even get close to having that many grandkids, we'll be lucky. But you also have to be healthy in order to keep up with all of them. So, again, one of the things, the recurring themes that I see, especially with my clients over and over again, people who are becoming grandparents are all of a sudden seeing, oh my gosh, I've got to do something about my health because I want to be around to see these kids grow up. And then I also want to chase them and have fun with them and do everything I did with my kids. So yeah.
It's really nice to be able to get out.
Yeah.
it's
Yeah,
really nice.
that's what I hear. But
I'm sorry, there's just a little lag there. I apologize. But it's
yep.
nice to be able to get on the floor with these kids and roll around and then be able to get back up, chase them out in the yard, push them on the swing, those types of things that are, are making life really enjoyable. And by learning how to kind of take care of ourselves and entering in programs like Ideal Protein, we really can do these things into mid and late life, you know.
Yeah. So I know that our listeners and our viewers are going to be interested to find out if you could just tell us a little bit, summarize your career in cardiology, and then that shift into a focus on obesity and how you saw that coming together.
Yeah, so I actually grew up. I live in central Wisconsin now. I grew up about 60 miles from here, and my dad actually was a family doc in town, in a small town called Shawnee, Wisconsin. And I sure thought for all the world that I would end up being a family doc. I mean, it seemed to run in the business. And then as I got into training, I enjoyed the specialty knowledge and the specialty procedures. So I ended up becoming a cardiologist. Finished up in Madison in 1992 and came here and joined a group of cardiologists. And for the first 13 years, I did stents, put in the stents, did interventional
Okay.
procedures on patients, and really enjoyed that. Found that very challenging. But like in life, anytime after you've done things for a certain amount of time, it's nice to find new and different fish to catch or something
Yeah.
different to try. And my wife has a 13-year cycle for her careers, and so after, I guess, for 13 years, so I guess it was time to do a change. So I switched to non-interventional cardiology. And interestingly enough, one of the reasons I sort of got out of interventional cardiology is that at some level I was just feeling we weren't dealing with the root problem. In other
Mm,
words, especially, it's a kind of an interesting transition. But when I started in the 80s and in the 90s, it was tobacco. Been relatively
okay.
thin
Okay.
in the middle of life with tobacco related problems, right? And then slowly in the 90s, you kind of saw that kind of dissipate. And then in the 2000s, you started to see the beginning of the obesity epidemic and the start of the
Okay.
crisis. By the time I kind of got out of interventional cardiology, the obesity epidemic was hitting full swing. And I just sort of realized that, putting stents in these people when they kind of get to that end point, if you will, was certainly helpful and certainly something needed to be done. But
Mhm.
we were really working at the downstream portion of their disease process, right? I mean, by the time they have a heart attack or angina and they need a stent, they've been dealing with chronic diseases for quite a long time. And, while it was interesting and satisfying, I really wanted to get upstream of that a little bit more. That was
Yeah.
obviously
Wow.
yeah, that was obviously before I started with Ideal Protein, but I realized sort of at the end of the day, we needed to get to help to these people before they got to the cath lab table, if at all possible.
Yeah.
And so I,
Wow. And that's, you haven't said anything, we've been talking, but that is fascinating transition, like you said, from tobacco related issues and then shifting towards food and obesity related issues. Um, to be able to see that trend is absolutely amazing. And now it's just balloons. The obesity epidemic has ballooned.
and I think at some level that's something that gives me hope for the future, because if you think about tobacco in
Hmm.
the 50s, 60s, and 70s, it was a huge business. People were making a ton of money on it. But eventually public opinion shifted, right? No advertising on TV. It wasn't popular. Actors and actresses do it now, but it's usually in a much different format than it was in when it was glamorous in the 60s and 70s. And so when you saw that thing, saw society move away from tobacco, smokers now have to go 100 yards from the hospital. Used to be able to smoke in the doctor's lounge, for gosh sakes. You know,
Right.
and and so my hope is that as we realize the next crisis, obesity, maybe we'll get the donuts out of the doctor's lounge. You know what I mean?
Oh,
Maybe
absolutely.
maybe the hospital will stop selling soda. Maybe the hospital will stop selling
Mm.
ice cream shakes for 700 calories. And so my hope is that, as people realize, oh, wait a minute, it's not tobacco now, it's obesity, that society has done this before and they will motivate again and we will see improvements in the future. So I am hopeful about that. Obviously, it takes a lot longer than some of us that see this problem now would like. But anyway, I guess we already wandered kind of far away from the question.
No.
Why don't you bring me back home on that?
Well, we're not. We're going to keep wandering because that was just such a brilliant insight that I knew was going to happen. That actually gives me hope. It just seems more and more we're swimming upstream in so many areas, and we're always fighting the current. And one of the things we're going to touch on is just the climate of sugar in our sugar, sugar being in Home Depot and Office Depot, and not just in the grocery stores, but we are exposed to that and we're pummeled with marketing. You actually just gave me a whole lot of hope that there might be a shift.
Yeah, I mean, I think sooner or later there has to be. If you look at the levels of this in our young adults or middle-aged adults, it's just unsustainable, and we're going to have to sooner or later move past this. And whether it's the government or even free societies, you're already starting to see more and more products, uh, low sugar protein bars. You couldn't buy them 5 years ago, right? Now they're everywhere.
Right.
You obviously still lots of soda, but there's a lot more unflavored teas. There's a lot more unsweetened beverages that people can buy, water. So I do think, as people get educated, as patients and people want different things, as movements start, and I mean, like anything, poor Dr. Adkins kind of bore the brunt of being a lunatic, 20 years ago, or more than 20 years ago. But now you're starting to see more and more people talk about avoiding sugar. It's become mainstream, and people are sort of realizing that sugar and ultra processed food is really the cause of this problem. Obviously, it takes a long time to move that curve or change that curve,
Yeah.
but you're starting to see it. I mean, there is no doubt about it. We have, I guess we shouldn't mention any trade names, but we have a lot of quick markets, if you will, here. Back in the 60s, when you went to buy gas, it was cigarettes and mints, right? And now when you
Right.
go to buy, you have to walk through 16 aisles of sugar. But even there, if you look, they're starting to get beef jerky, they're starting to get nuts, they're starting to get peanuts, they're
Yep.
starting to get fruit, they're starting to have veggie trays. So even that market, I think, is starting to change. And as consumers, obviously, we have to kind of support that, right? We have to walk past the chips and move our way and buy the nuts and buy the beef jerky and buy the apples. And then the market will respond. If nobody buys the chips, they're not going to stock them. So I do think that there is some hope. Obviously, it's difficult, no doubt about it. But I am hopeful. Yeah.
Yeah, no, that's fantastic. So as we're getting, we'll go back to our outline, but
Let me just finish up how I ended here. And then I think that was the
yeah,
question originally, and we wandered far and wide. I apologize for that. But so anyway, so we wanted to get upstream of that, try to get ahead and help these people before they got to the cath lab table. And then so we, really there wasn't a lot of tools, and a lot of the medical training is really, I mean, I guess maybe we shouldn't say terrible, but it's just not very helpful. Certainly, the low fat craze and the low fat diet that everybody was trained in back in the 80s and the 90s was certainly a large part of the obesity epidemic. People can remember the snack well diet, if you will, where there was low fat
yep.
cookies. Those are supposed to be good for.
Oh,
I mean, I remember red licorice and bagels being, American Heart Association certified or something. It's like,
yeah,
well, because
yeah,
there's no fat in it. It's like, holy cow! You want to make somebody sick? Put them on that. So we had to kind of get rid of all that baggage. I had to get rid of that personal baggage myself. And then back in 2012, came in contact with Ideal Protein, and met with one of the kind of the guys that brought it into the country. And he and I hit it off, and for some reason, got me at a vulnerable moment, got me to do a pilot, which I think is actually a great way to start the program.
yeah.
We were gonna do 50 patients. Basically, we experimented on our staff, if you will. Our staff was open-minded to do it, and we had such great results that it was just kind of off to the races after that. And at one point in time, we got up to about 350 patients any one week that we were treating. Between the pandemic and
Wow.
market, obviously that's declined at some point in time. Where I just found out today we're back up to about 10 or so. So still a pretty good sized program. You know, when we started doing this in 2012, you know, people thought we had three eyes when we talked about a ketogenic diet, and we
Right,
talked about,
right.
you know, and you know, you can't do that. This is totally dangerous. And it's kind of weird how people can deny what they see. And maybe that's another tangent we can go down if you want. But
Wow. Yeah.
we, you know what I mean? I mean, so we would put these patients on diets on the ideal protein protocol, and their medicines would come off, and their weight would come off, and their labs would all look better. And then people would say, "Well, you're killing them." I'm like,
Right, right.
really? Because they looked to me like you were killing them before, and I'm trying to save them. Which, you know, I mean, come on, they're 40 pounds less. They're off their blood pressure medicines. They're off their
Yeah.
everything is better. How could I possibly be hurting these people? God. Anyway, I apologize for that. But anyway,
No.
so once we got results and got going, but nowadays, you know, quite honestly, it is a little bit tougher to run a ketogenic protocol because people are doing it online, they're doing it on the internet, and I think maybe the corollary or the tangent or the thing about that is that none of those programs have the ideal protein magic, which I think is the coaching.
Yeah.
Yeah.
Yeah. Well, you
Yeah.
know, that's the thing though, right? I love hearing all of this coming from a cardiologist with your background. Like you said, you know, Dr. Atkins kind of pioneered some of these thoughts and really tried to generate some steam behind it. And for all the flack that he was given, now we're finding out that most of the science behind what he was saying was correct. And so, you know, when you say the term ketogenic, when I started doing this 6 years ago, it was kind of like, and then we really saw the trend and the boom. But do it yourself keto is there's so many resources, there's so many conflicting ideas. Patients just they have no idea how to put it together, and that's where the structure of the ideal protein protocol and the coaching, having a coach to navigate through the jungle of keto is, I think, essential.
Yeah, I think that's the magic of the protocol is the once a week coaching, um, and coming in, getting your questions answered, get reassured that you're doing okay. You know, it's okay that you didn't lose weight this week. You'll probably get it next week, and answering all those questions, and you know, even quite honestly, making people pay for it. Right? If you're paying for it, you're more likely to be compliant. You're more likely to come in. You're more likely to be successful. If you read about something online and you try it for 2 days and it doesn't work, you know, maybe, you know, most people aren't going to stick with that. So I think the coaching, the being responsible, the commitment
Yeah.
that you have in the program, I think that's really what makes it successful and really what makes it work. And that's been our experience. Absolutely.
And that brings us to a point that we talked about, that I've heard other Dr. Tran talked about as well. You know what? Being overweight or obesity or metabolic syndrome might not actually be your fault. We have been misled as far as what healthy eating is supposed to have been. However, even though it's not your fault, you are the only one who can change it. It is your responsibility ultimately. We're here to guide you. We're here to give you the tools, etc. But you know, you have to be instrumental in your own transformation. And so you and I, one of the things that you talked about during your talk with Ideal Protein is the concept of looking at obesity or being overweight as a disease. And from that standpoint, can you elaborate on that concept?
Yeah, well, it's certainly, I mean, to start with, it's been declared a disease by various different organizations actually several years ago. And if you think about it, you know, it just makes sense in a lot of different ways. Number one, how are we going to treat it if we don't declare it a disease, right? How are you going to treat it effectively if we're not treating a disease? Number two, who would choose to be obese? Nobody would choose that. It's a difficult lifestyle. It's a less than a possible or a full life. You know what I mean?
Yeah.
Nobody chooses that. And number three, the current society is designed to make us obese, obviously, right? Because we all are. There's only a small percentage of the current population that is metabolically healthy. You can guesstimate it, but it's probably around 15 or 20%, 20%. So probably 30 to
Yeah.
40% obese, 30 to 40% are overweight. And then there's another small percentage of that skinny fat, if you will. So really the people that are metabolically healthy by
Mm-hmm.
far minority. So it's not clear to me why 3/4 of us would choose a lifestyle that makes us sick. And I think I heard on one of your podcasts, John, where people are given over 200 food choices in a day, and about 99% of those have got to be food that makes you sick. Food is designed nowadays to overeat it. Food is
Yep.
designed to sell. Food is designed to give you quick, spontaneous decisions. If you think about it, if you have to sell food and the population isn't growing a lot, the only way to grow your food sales is to get people to eat more.
Right.
Right.
Wow. Yep.
So
Absolutely.
we're producing, when my grandpa was a farmer, and don't quote me on these numbers, but the concept, my grandpa was a farmer. He probably raised 50 to 100 bushels of corn an acre, right? Nowadays, we're raising 3 bushels of corn an acre, right? What are we going to do with all that corn? Where's it all going to go? We have to eat it.
Yep. And they make it into corn sugar and all
Right.
kind of corn syrup and
Right, corn syrup and right. So anyway, the whole society is currently designed to make us obese. I mean, I do think that harkens back to some hope in the future where things can change. But no, obesity is a disease. You have to think of it as a disease if you're going to treat it. Otherwise, you're not going to be successful. And we have to give people tools to deal with it effectively, which we certainly have not done in the most part.
And so that's where, too, we come from in Ideal Protein as clinic owners and coaches. We come from that mindset, and as a doctor who's doing Ideal Protein, we come from that mindset of using the Ideal Protein protocol. Number one, it's a protocol; it's not a diet, and number two, it's actually designed as treatment for the cause of the obesity disease. It actually restores metabolic health first, and then that's how we lose weight. Can you speak to that concept?
Yeah, I was talking with my wife yesterday, and different diseases have different levels of commitment on the patient. In other words, if you get appendicitis, some surgeon can lay you down, take your appendix out, and you're cured. And you had to almost have nothing to do with that process, right?
Yeah, right.
Right.
Can't help.
But if you get degenerative joint disease, you might have to be involved in physical therapy to get better, range of motion to get better, right? If you develop asthma or COPD, you have to take your medications. You maybe have to give up smoking. And so obesity is a disease, but it is a disease that, we have to help patients learn how to treat for a large part themselves. I think Dr. Tran, one of his famous lines is, but I can't eat for you. You have to learn how to eat yourself. And maybe that's a paraphrase of that. I apologize.
Wow. Yeah.
But the treatment is changing the diet. I think diet itself is sort of a dangerous word because some people use diet as a fad diet, right? The cabbage diet or the hot dog diet or whatever. And that's not what we're talking about. We're talking about as a diet what you eat every, you know what I mean? And how that food is information to your body, how your body responds to that information, and how that makes you either sick or healthy depending on what you eat. So yes, obesity is a disease, but it is a disease that patients to a large part have to learn how to kind of deal with on their own. It's a disease that they'll have their whole life. You know what I mean? Every day, for me, every day I have to think about it. You know what I mean?
Yeah. Oh, absolutely.
I'm sure you lost 70 pounds. You have to think about that disease, if you will, or that process every day, right? Some days you're going to do well. Some days you're not going to do well. It'll be a Packer game or whatever it might be. And, I forget what part of the country you live in.
So I'm outside of Washington, D.C. So funny you mentioned that. I was at a couple of Nats games, a couple of baseball games this weekend, and might not have done as well as I should have. But it's great to be back out again.
Yeah, right. But the good news is you've learned a process to deal with it, and so you realize, okay, I had a couple of bad days, but we're going to have a couple of good days, and everything will be okay.
Right. Yeah, absolutely. Well, but and the backside of that is, this maintenance journey after you've gone through your initial weight loss it is quite a journey. Again, a coach is absolutely essential. We don't want people to disappear after they reach their weight loss goal. We want to teach them the right nutrition, the appropriate macros, et cetera, for their individual body's needs. And it's an ongoing process. But it's worth it because darn it anyhow, to feel this good at this age, I wouldn't trade it for anything at this stage of the game.
Yeah, I think Yeah, especially at that age, I mean, I'm 61. I don't know how old you are, and you don't need to share that. But if one of the things that kind of got me really interested in this is, I wanted to be active late in life. I worked a lot as a young adult and trained a lot, and so delayed gratification, if you will. You know what I mean? Until my 50s until my 50s, and now that I have a little bit more time, I want to be active and do that. And one of the fundamentals to being able to do that is obviously to be healthy. And I learned from watching patients go through their life journey that if you don't have if your health, if you don't have your weight under control in your 60s, in Wisconsin, to hunt white-tailed deer, you have to climb up into a tree, right? And
Ah,
ladders or steps or whatever. But
yep.
as I started to do that in my late 40s, early 50s, I'm like, ooh, if I want to do this into my 60s, I better kind of put the chips away and move on to something else. You know what I mean? So yeah.
Yeah, well, that's the thing, right? So, like you said, everybody works super hard. They sock away money. They're looking forward to retirement. And how many of them actually get to enjoy that retirement? How many of them actually get to live that life possible, whether it's, on the golf course or in a tree, hunting or fishing somewhere? Super, super important to invest in your health just as much as you're socking away in investments on the stock market.
Absolutely.
Um, so to bring us back again, I just want to explore this topic of metabolic health. Now is one of those buzzwords, buzz phrases that we're hearing in the media, and I kind of like for our people to um, get a little bit more in tune with that concept, and also the concept of insulin resistance, which underlines so much of what we refer to as metabolic syndrome. Can you kind of unravel that for us and make those connections?
Yeah, I can. And we'll do the best I can. I'm not a world's expert in insulin resistance. There's a lot of great resources out there now. I think a good series that people, we have a reading list that we developed for our program. We can share that with you if you would like.
Oh, yeah.
Just have to reach out to me or to Sam or something like that. But I think a good series of books that really nicely explains insulin resistance for most of us is Dr. Jason Fung's books on the obesity
Mhm.
code and the diabetes code. And so a lot of my understanding of that actually came from him. Hopefully, he won't listen to this as I butcher this explanation, uh,
Hey,
but
maybe I can get him on the show.
yeah, yeah, definitely. If you could, it would be a great idea.
Oh, yeah.
He's really good at speaking. I've never actually met him, but a lot of his stuff is really good out there. But anyway, because I think it's kind of hard to understand, and I think maybe the best way to understand it is the current diet, standard American diet, or SAD, if you want to call it, which I think is a
Yep.
great acronym for it, has caused our cells to already be full of glucose, sugar, glycogen, right? So you eat
Yep.
something, and insulin is supposed to go up, put the sugar into the cells, get it out of the bloodstream. You don't want sugar running around in your bloodstream. It's not good for you, right? So insulin's supposed to go up a little bit. Sugar goes into the cells. You burn it off. It's gone. You're ready for the next meal, right? Okay.
Yep.
So now, once the cells start get too full of sugar, if you will, they're like, man, hey, wait a minute, I don't really need this sugar. And but then the pancreas and the body's like, well, we don't want it in the blood, and the cells are like, we don't want it either. Well, then your
Yep.
insulin level to go up higher to force that sugar into that cell, right?
Yeah.
cells get cells get fuller and fuller, and I think when I think about it this way, this sort of explains a couple different tangents that we can maybe get into. But one of them is this fatty liver disease that we're saying, which is a big place for the glucose to go, right? So your insulin's going up. You're trying to clear the bloodstream. It's going into the liver, making you sick there. It's going into the pancreas, making you sick there. It's going up. Your insulin's going up. Your sugar's trying to come down. At some point, no matter how much insulin you make, you can't overcome that insulin resistance, and then you get hyperglycemia.
Yes.
And I think, I mean, I'm sure there's maybe some intricacies that aren't, but I think that's the best way to think about it. I think that's a way to explain it. I think that's a way to understand it. And it just makes sense to me that way. Right. And then if you think about it that way, to a certain extent, some of the things that we've done for type 2 diabetes, but have been difficult to show that it works. So insulin for type 2 diabetes, right?
Yeah. Yeah.
Blood sugar, and it probably helps some what they call microvascular complications, um, kidney, that type of stuff. But it's never really been shown to limit the development of heart disease per se for insulin. It's been really hard to show some benefits in insulin and that type of stuff. And if you think about it, giving more insulin to somebody who's already insulin resistant to a certain extent
Right.
is
Right.
making the
It doesn't make a
worse.
whole lot of sense.
Right. It's making the problem worse, right? Yes, you're lowering their blood sugar, and people kind of call that a glucose-centric view of type 2 diabetes. We're treating their,
Right.
I'm sorry.
Yep.
It's going to go to voicemail here in a minute. I apologize for that.
No worries.
But we're treating their blood sugar, so we're getting that down. We can measure that. That's a nice result, but it's not fixing the metabolic problem, which is insulin resistance. Oral sulfonylureas, pills that have been on the market for a long time, never really been shown to improve prognosis, probably for the same reason. They just raise your insulin. They aren't treating the underlying problem. And now when you look at the new drugs that are out there, the SGLT2 inhibitors like Jardiance or empagliflozin, and then the GLP-1s like Victoza, those actually seem to lower insulin, lower insulin resistance, and improve weight. And those are actually showing a markedly improved prognosis, right? Same thing with metformin, which treats insulin resistance, and those actually improve prognosis. So I think when you start to think about it that way, then the things that you see start to make sense. And then to me, it makes sense when you remove sugar and remove processed starch from the diet, the cells aren't full of that crap. And then the insulin that you have can start to work again.
Yeah, it's kind of fun. It seems like the last that we've come to is the whole idea of limiting sugar or limiting carbohydrates as an approach to treating insulin resistance and type 2 diabetes. It is truly amazing when you just ran through a list of medications that doctors will go through in trying to treat type 2 diabetics, instead of right out of the gate just saying, look, let's get rid of the sugars, the starches, the super processed foods. Let's start there and see what happens.
Yeah, and it's really, to a certain extent, it's sad, and I think at some level it's unfortunate that type 1 diabetes and type 2 diabetes have a similar name, because they're like totally different processes, right?
Yes.
Type 1
Yep.
juvenile onset, low insulin, you need insulin, boom. You know what I mean? They both have high glucose, but totally different process. Type 2 is because you have too much sugar. And so it's very interesting. I think the low fat thing kind of confused us as well, because, type 2 diabetics are high risk for heart disease, so we got to limit their fat to protect them from heart disease. But then we
Right.
told them to eat sugar, which then made their diabetes worse. And
Yeah.
so, don't eat fat because it'll give you heart disease. Well, we can talk about that tangent, but it's still being pretty high debated. And probably we don't want to go down the rabbit hole, but certainly telling them to eat more sugar made their diabetes worse. You know what I mean? And insulin.
Yeah. Oh, absolutely.
Giving their insulin made their weight worse, and giving them oral sulfonylureas made their weight worse. And right, it's kind of boggles the mind that telling people with a disease caused by sugar to stop eating sugar is controversial, but in some level it still is. And I think because of those historical contexts of, eat sugar so you don't eat fat, and keep your blood sugar the same. And no, it's just stop eating sugar and all the other stuff goes away.
Yeah. No, absolutely.
Thousands of times. I've seen it thousands of times.
That's the thing, right? When you were talking about the numbers of patients coming through your practice, when you see it that often, there's no debate, no arguments, and that's what just more doctors need to see those results.
Yeah, and maybe people don't see it because the food is everywhere and people can't stop it. So in their individual practices, they don't have very many people that stop sugar. But there's getting to be an overwhelming amount of data now. Another great author is Gary Taubes, who wrote a lot of books.
Yes.
The Case of Sugar, I think, is a really pretty good one, and a good one to read. There's one called Good Calories, Bad Calories, which is, if you like, highly referenced stuff, but it was difficult to read. I had to put toothpicks in it times because it's so highly referenced and so scientific. It's not. Nina Tico wrote one called The Big Fat Surprise, which is really very good as well.
So yeah, I'm gonna stop you there too, because when you were talking about speakers and authors, et cetera, you just literally ran down the bookshelf that's in my office. And Nina is also one of my favorite authors and heroes in this space. I know that you've presented with her. You know her, or
A presentation by her, and we in October of 2020 we had her booked at a speaker for a conference that we were going to have on obesity, and you can kind of guess what happened to that. So
yeah, unfortunately, but hopefully we'll get back to it.
right, exactly.
So, Doc, I want to kind of shift gears here too. Now, we've talked about you having the Ideal Protein program in your clinic. I'm a chiropractor by trade, and so I'm a non-referring physician. But for me, like you were saying, it's so incredible to have kind of a shift in gears and a second career, et cetera. I have just gotten the hugest kick out of being able to transform people's lives using this protocol. And one of the things that I would most like to do is develop collaborative wellness relationships with the doctors in my area. I would love to connect with cardiology practices, primary care offices, so that they might see me as a great resource for their patients. So I could take care of the nutrition piece, and they could continue to take care of their other piece, but we could work together for the benefit of their patients. Can you speak to that concept? What would make physicians feel comfortable referring their clients to an Ideal Protein clinic near them?
Yeah, I think that I've been thinking about that a lot. I did for the audience. I did get the questions ahead of time, so I've been trying to cheat a little bit, and think about that a little bit. And I think as I was thinking about that, as in most things in life, I think it comes down to relationships, John.
Yep.
You know what I mean? Advertising, even data-driven results, like we talked about, people can ignore the data, or they can discount it, or they won't see it. So I think at some level it comes down to relationships, right? And I think if you were serious about wanting to do that, you need to find a physician that you can have a relationship with.
Hmm.
Golfing buddy, fishing buddy, Nats fan, uh, or just an interest in preventive medicine, a physician that has an
Yes.
or wholeness. And then I think you really have to single that person out, that lady or that gentleman, and take them out to lunch, show them some
Hmm.
data. We talked, this is a slight tangent, but there's a lot of data. Almost any low carb study that you can pull is going to show improvement over low fat diets. There's a company called Verta Health now, which has a couple of really good studies with totally different model than Ideal Protein, but just showing reversal of diabetes by getting rid of sugar. And so I think you can speak to some of that data. You can share your own anecdotal studies. You can certainly, Ideal Protein has our data right here.
Yeah. So as you're bringing up that, I've got this slide up that shows statistics or data from a research project that you were in charge of through Aspirus. Is this correct?
Yeah, so when we started this thing, 2012, again, we talked about it a little bit, but it was slightly unique and people weren't doing it. And there's actually, we're part of Aspirus is a moderate sized healthcare system. And there's some people in town that maybe thought what we were doing wasn't a great idea. And so we wanted to
Mm.
kind of report our results to disprove that. So I think actually for the first 2,000 patients, we did a baseline lipid, and of course we did all the other metabolic or all the other parameters. But we did a baseline lipid and a baseline blood sugar, and then 12 weeks later, we recorded their weight, their blood sugar, and you can see as everybody that's in this space knows, 12 weeks they lost about 14% of their weight, their cholesterol came down. It's interesting, tangent I think, but LDL cholesterol improves a little bit. LDL cholesterol itself is probably not super diet sensitive. We did
Right.
a study
Right.
on 16 patients where we looked at what's called advanced lipid panels, where you look at big LDL particles, small LDL. So small LDL particles are dense and they penetrate the artery of the wall easier.
Hmm.
So they're more
Hmm.
likely to cause atherosclerosis. Big LDL is fluffy and it doesn't penetrate. So you can have the same LDL number, if you will, and some people will be much more likely to have blockage at that number than others based on the size of their LDL, right? So
Yeah,
even though,
yeah, I've heard that.
yeah, so even though LDL doesn't come down a ton, we know that it changes from small, dense LDL to big, fluffy LDL, which
Big
is more
fluffy.
atherosclerotic. And how you know that without doing the advanced lipid studies is the triglycerides. So when you see
Yeah.
triglycerides come down and you see HDL go up, you know that you're changing that LDL from small, dense to less atherogenic. And I think it's a
Uh,
it's interesting. Those people that try to treat triglycerides with pharmacotherapy, uh, it's been a really frustrating process to me. By far and away, the ideal protein protocol is the best way to treat high triglycerides. Unbelievable results. And we got a
it
couple
is,
different.
yeah. It really is. When you have clients bring in their blood profiles before and after, triglycerides is just a no-brainer.
Yeah.
HDL goes through the roof, triglycerides go into the basement, and the more research that I'm reading says it's that ratio and those indicators that are really the best indicator as to potential issues with heart disease.
Right, especially for diet-induced heart disease. If you have familial hyperlipidemia and you're like my wife, your LDL cholesterol is 190, well, that's not diet related. You know what I mean? That's not a diet disease. That's a
Hmm.
genetic, and those are moderately common as well. But yeah. So I mean, so the data is out there that you can see and you can show, and the glucose obviously is better, but just realize that we stop oral sulfonylureas basically as soon as people are in the protocol. We're cutting down insulin, so you're seeing a better blood sugar on a lot less medications there.
A lot less, yeah, yeah. That's kind of the huge point there. Also too, just in this 12 weeks of this study, weight went down an average of 14%, right? 14% of body weight, correct?
Yeah, right. Yeah. And so
So, one
let
of
me go
those
back. Let me
statistics
go back.
that's out there is, yep,
Let me just go back to finish
yep,
up how to get going on that, and then we can talk about that 10%. But I just kind of want to finish this because I thought about it a lot.
okay,
What you would want to do is, if you're going to try to do that, is to find a physician that you think somehow you could partner with, and then ask him just for a couple people. Just give me one or two. You know, and let's see what
hmm,
happens. See what kind of results we got. You know what I mean? And then I would think you would set up a protocol. Uh, okay, the guy's going to start on May 1, and I want you, the doc, to see him every month so you can withdraw his medications as we're going through. Or you set up a medication withdrawal protocol. We can share ours with you. But you would develop a collaborative protocol where if this guy's staying in the program, or this lady, this person, you're going to see him every month, every 2 months. And, we're going to send you notes every week as to how he's doing. And we're going to develop this collateral protocol. And no, you don't need to send me every patient. I just want one or two. I just want to prove what I can do. And
yeah,
if you get a couple, and you're successful, the changes that these people are going to see, I mean, there's no medicine available, especially now. I mean, that really can do what the protocol can do.
yeah.
It's just
That's
those
absolutely
advances.
amazing.
So I guess that's how I would suggest that the clinics that want to get into start it, get a relationship, go over and buy them lunch. Maybe it's not the physician, maybe it's the nurse practitioner, maybe it's the nurse manager. Uh, you know what I mean, or somebody like that
Hmm.
that influential that could really kind of get you in the.
Oh, I lost you, Doc. Oh, hang in there. We seem to have lost the Doc. Oh,
Oh,
he's coming back. There he
yep,
is.
yep. No, that was the Packers calling me. They want me to try out this summer here.
There you go. Still haven't given up on that dream, huh?
Okay, great. I always take the Packers first call. Yeah.
There you go. I would too. Hey, it's funny that you mentioned that approach, and we were literally starting to do that right before the pandemic hit. We were approaching clinics and trying to set up that lunch. I gave a presentation at a podiatry office. We brought them lunch that was phase 1 compliant. Went through a PowerPoint presentation with them, and we were getting ready to really do that when everything shut down. And it was harder to get in a medical clinic than it is, a
Yeah.
restaurant. So we're hoping to do that in the very near future here as things get a little bit more at ease.
Yeah, no, I think that would be. I really have. No, I thought about that a lot. I think that would be the way to do it. Is just a relationship, not an advertising budget at all or anything, and just developing
Yep.
that collaborative relationship as to here's what we're going to do, here's what you're going to do. Here's when I think you should see these patients. When do you think you should see those patients? That type of stuff.
Yep.
And how do we make sure we're both all on the same? We're not competing. We're working
Nope.
together. Poor family docs, man, they got about 8 minutes with each patient. There's no possible way they can deal with this program, and then most of them haven't been trained in it. A lot of people are still told to tell your patients to eat less and exercise more, which obviously,
Right.
if that worked, 3/4 of us wouldn't be sick. We've been saying that for 30 years. It's obviously not working. It's eat better or eat different. So, but that's kind of all their training. Eat less, exercise more. Okay, I'll see you in a year. Well,
yeah. Well, like you said, if they've got that little time, that's about the only advice they could give. Or they could have a really quick structured conversation where they say, you know what, I'm going to give you this brochure for this program. There's a clinic down the street. They probably have an introductory seminar that you might be able to attend to hear information about it, get your questions answered. But I think this might be a great approach for you.
Right, exactly. And I've had 5 patients do it and they're really happy.
Yeah.
I agree.
Yeah. Fantastic. So let's go back.
Yeah, go ahead. I was going to.
Let's go back real quick. Yeah, the benefits of 5 to 10% weight loss.
Right. So we talked about that a little bit initially about the liver getting full of fat and the pancreas getting full of fat. And I think what happens is that, and maybe this harkens back to why people don't view obesity as a disease, is because you can see obesity, so people think it's a cosmetic problem, right? But a lot of fat really isn't that metabolically active, right? There's sort of 2 complications with obesity. So one is the complication of the weight on the joints, on the skeletal structure, all that type of stuff, if you will. But then there's also metabolic complications, right? On the organs, where fat is where it shouldn't be. We see it in the heart with fat in the atrium that causes atrial fibrillation in the obese patients. Well, if you lose 5 or 10%, that 5 or 10% comes from the parts that are causing the worst problem. So it comes from the pancreas. It comes from it comes from the heart, right? So cosmetically, you might see a minor improvement, but your body's like, wait a minute, all this fat in this liver is not good for us. Let's get rid of that first. All this fat in the pancreas, all this fat in the heart is not good for that. We're going to get rid of that first, and then we'll worry about the hips later, or maybe we'll try real hard to hang on to that because, right, evolutionarily, it makes sense to hang on to some fat, right? But it doesn't make sense to hang on to fat in your liver, in your pancreas, in your heart, and that type of stuff. So that 5 or 10% comes from the organ fat or the the sick fat. And so that gets better with weight loss. And that's why, when somebody loses 5 or 10%, I mean, you see that all the time. Their blood sugars are down, their blood pressure is down, their medicines are going away. And you're just, at the extreme is obesity surgery, where 3 to 5 days after obesity surgery, people are much healthier already.
Wow. Yeah, no, that was a fantastic explanation of that 5 to 10%. I hadn't heard it explained that way. That makes a whole lot of sense.
Right. And you get improvement in hormones. You get rid of the hormones, the high insulin and all that type of stuff that's causing the problem. So, yes, it is a cosmetic problem, but it's much, much more than a cosmetic problem. And you're treating the metabolic problem with 5 or 10% weight loss.
Wow. All right. Thank you for that too. Let's bring this home. One of the last topics I wanted to touch on, because again, it was such a poignant presentation that you gave to our company in the middle of the pandemic, is discussing the importance of metabolic health and weight and COVID-19. It seems to me that, yes, we're doing fantastic with the vaccination rollout and numbers are changing, et cetera. But we are going to have to live with COVID-19 in the environment now. And I think a lot of us would like any extra reassurance we could have that in our body's ability to fight and survive. Can you talk a little bit about the importance of metabolic health and weight and our ability to fight COVID-19?
Well, yeah, I mean, like we've been saying, obesity is a disease. So underlying diseases make you less likely to fight off the next disease or the next problem, right? So whether it's COVID-19 or the flu or the next virus that's certainly going to come down the line in this globally connected world, you want to make yourself as healthy as you can be to fight off the injuries that occur with living in the current world. And so there's no doubt there's lots of data to suggest that obese people's immune systems might be quite as strong. COVID-19 specifically set off an inflammatory condition, which is what kind of irritated the lungs and caused this pneumonia. So if you're already inflamed and then you get pro-inflammatory disease, that's obviously going to make things worse. There's some thought that COVID-19 itself is sequestered in some of the fat cells, so these people might have a bigger virus burden as well.
Mm-hmm.
So,
Yep.
I mean, I think at the end of the day, there's some COVID-19 specific things, but there's just making yourself healthier so you can fight whatever else might come your way. You know what I mean?
Yeah, yeah, absolutely. Um, I thought that one of the neatest things. This is. Oh, I want the slide to come up. There you go. If you could kind of speak to this slide a little bit, though. Um, all the different factors, whether they're biomechanical, right, as far as obesity and the burden that you're putting on your lungs and your ability to breathe in the first place.
Yeah, right. That goes to kind of what we talked about, sort of the two different pathways of complications of obesity. So the biomechanical factors we talked about, degenerative joint disease. So, the COVID-19, when people get real sick, is a respiratory problem. Well, people that are large, they're, when we look at their chest X-rays, their lungs are small, right? Because everything is pushing them up. So if you have less lung reserve because you're sick from the current standard American diet, you have less reserve, you have less ability to breathe on your own, more likely to be on a breathing machine, more likely to need support, that type of stuff, right? So there's those mechanical problems, and then there's these biochemical problems of lower immune system, but an already pro-inflammatory state, and then getting something that kicks that off makes things worse. So I think those two different combinations put people at high risk for COVID-19. Absolutely.
Yeah, absolutely. So improving our weight and improving our health metabolically can only serve us in the future as we move forward with this stuff.
Yeah, absolutely.
Well, I tell you what,
everybody get their vaccine, right? Everybody should get their vaccine, especially people that have the disease. Obesity should get their vaccine. Right.
Well, and it's been so neat to see. I don't know. It seems to me as if things, at least around here, have been rolling out very, very well. So many people are coming in saying, "Oh, I've got my second one," or "I've got it scheduled," or just so happy to see all of that. And it really is giving people the confidence to start moving about and getting back to enjoying some of that life possible.
Absolutely. Yep, absolutely. Certainly see the end of light at the end of the tunnel here.
That's what we're hoping. Well, Doc, I wanted to thank you for sharing this hour of your time with us. I've had some fun with you over the past couple of weeks, preparing for the show, and I hope it is that we do have super weekends again. I hope that we do get to travel, and I hope someday that we do get to meet in person. I would love to attend some of those obesity conferences. Andrew and I have talked about some ideas and maybe having some heavy hitters talk for ideal protein that you might be a part of. So crossing my fingers that some of this stuff comes to bear.
Thanks for doing what you're doing. I mean, we really need it. We really need all the help that we can get for these people. I just worry that a lot of our adults or kids, the life isn't as possible for them because of this current problem. And at some level, it breaks my heart, and I just really appreciate what you're doing to try to raise awareness and give some people some hope and some techniques to deal with this. So thanks.
No, thank you. It's a pleasure and a passion. All right, sir. Thank you so much. We will talk to you soon.
Go Packers. Thanks.
Yeah. He had to get one more in, right? One last go Packers. I love it. So there it is. Fantastic time with Dr. Timothy Logemann. He really shared some great insights directly from a cardiologist. So, I would hope that if you've got family or friends who are suffering from a lot of these chronic disease conditions that you feel could be helped through the Ideal Protein Protocol, that you will share this episode with them. As always, I ask you to like, share, subscribe to us. We're almost up to 1,000 followers on Facebook. Please keep that going. Remember, we are video on Facebook and YouTube, and we are audio on iTunes, Spotify, and just about anywhere you can get audio podcasts at Life Possible Podcast. If you are looking for an ideal protein program, you've been inspired by this show, I encourage you to go to the corporate website, www.idealprotein.com. There's a clinic locator for clinics near you. I myself run Barnes Chiropractic Health and Fitness in Centerville, Virginia, in the Washington, D.C. area, if you're interested in contacting us. So, as you can imagine, I am already hard at work on my next episode. I would love to share with you. Let's see if we can bring her up. Oh, there we go. The next episode will be airing next week. And I am going to be hosting Rebecca Wilson. Rebecca, her father was Dr. Paul Wilson. You recognize him in the picture there. Dr. Paul Wilson was on a couple episodes back. An incredible story, an incredible man, a primary care physician who was over 400 pounds and who used the Ideal Protein Protocol to change his life. He told the story about how both of his daughters then decided to use Ideal Protein to transform their lives after they were inspired by their father. I have had the privilege of spending time with Rebecca over the past couple of weeks as we're developing a show for next week. I'm not even waiting 2 weeks to get this episode out. We will have this episode for you next week. Rebecca Wilson is an aspiring actor as well as an educator. And as she tells the story to me, she had all but given up on acting, which is truly her passion. All had given up. She just was not getting the roles that she wanted. She felt like she wasn't able to put her best self forward. And when she did the Ideal Protein Protocol, it transformed her from the inside out. She is now back acting. She's having more fun than ever. She's getting roles that she's been looking forward to and living her best life possible acting life. So join me next week when we bring you the incomparable Rebecca Wilson. As always, thank you for joining me, and keep living your life possible.